Hi, Kennedy. Can you hear me?
Hi, welcome to the third mini medical school of 2021. My name is Kennedy Camden, and I am a first-year student at Indiana University School of Medicine. I will be moderating the session tonight, and I'm so thankful to have you virtually with us here tonight. Before I introduce our panelists tonight, I'd like to take a moment to thank the sponsors who have made the 26th annual Mini Medical School Series possible. A big thank you to Hamilton Center, Indiana State University, Indiana University School of Medicine, Terre Haute, Lugar Center for Rural Health, Minority Health Coalition of Vigo County Incorporated, Terre Haute Regional Hospital, Tribune Star, Union Health, Via Media, West Central Indiana AHEC, and WTHI TV. Tonight, I would like to explain the logistics for tonight's event. The Zoom webinar platform is going to allow us to feature our local expert panelist. All other attendees are going to be muted during his presentation, but I do encourage you to submit your questions throughout the presentation using the question and answer button located at the bottom of your screen. Your questions will be answered by our panelist following a brief intermission after his presentation. Tonight's topic is going to focus on urology, specifically enlarged prostates. The panelist for tonight is Dr. Michael Shanks. Dr. Michael Shanks is a urologist in Terre Haute, Indiana. He joins the active medical staff of Terre Haute Regional Hospital and the physician practice of Regional Health Urology. Dr. Shanks earned his medical degree from Chicago College of Osteopathic Medicine at Midwestern University in Downers Grove, Illinois. He continued his education with a urologic surgical residency at Franciscan Health in Olympia Fields, Illinois. Prior to joining Regional Health, Dr. Shanks has been actively involved in the care of patients both in the U.S. and overseas. He has served on the South American medical and surgical mission teams in Bolivia and Ecuador, providing remote mountain and village medicine, the Africa Medical Mission Team in Burkina Faso, and in Cape Haitian in Port-au-Prince, Haiti, offering remote village and hurricane survivor medicine. Dr. Shanks believes in the importance of community service, and during his urologic training, participated in many community service activities, including prostate cancer screening at the Chicago Prostate Center. He has an interest in both male and female general urology, particularly the treatment of stone disease, BPH, erectile dysfunction, female incontinence, and genitourinary oncology. Dr. Shanks has received the Eurolift Center of Excellence designation. This designation recognizes his commitment to exemplary care for men suffering from urinary tract symptoms and his achievement of a high level of training and experience with the Prostatic Urethral System. In his spare time, Dr. Shanks enjoys spending time with his family, water and snow skiing, traveling, and doing domestic and international philanthropic mission work. And without further ado, Dr. Shanks, please take it away.
Good evening. Thank you very much, Kennedy. Welcome everyone to this first Zoom mini medical school meeting. I must admit that this is my first Zoom meeting, so bear with us if we have a few technical difficulties, but Kennedy will help us through that, I hope. Again, thank you for that warm welcome. My name is Dr. Michael Shanks. I work at Terre Haute Regional Urology, and I'm a urologist that's from here. I'm from Terre Haute. I trained in Chicago and decided to come back home and treat the community that brought me up. And so I was asked and privileged to talk to you today and speak to you about urology. And urology in and of itself is a very wide-ranging discipline and has a wide spectrum of disease processes, both benign and malignant. And so to cover all those disease processes would be very difficult in a short amount of time. And so I thought I'd focus on one of the more common reasons that folks come to see me in the office, but also let the attendees know that we're not just focusing on that. At the end of the Zoom meeting, we'll have open this to questions, and you can absolutely ask any question about any organ system, urologic organ system that you'd like. It doesn't just have to be enlarged prostate. So I definitely want there to be open communication about all urologic diseases. And today we're just going to focus on enlarged prostate, as it's one of the more common reasons I see folks in the office. And so we'll go ahead and get started. I have a quick PowerPoint here. As Kennedy so eloquently described, we are a center of excellence at Regional Hospital for a procedure for enlarged prostate, which is a minimally invasive procedure that addresses the obstruction or the plumbing problem that enlarged prostate causes. And so as far as our attendees go, it looks like there are a few men here, but also, you know, for the women out there on the Zoom call, this is also important to you because your men and your husbands are probably annoying you by their urinary frequency and urgency and getting up multiple times a night and waking you up, and you know, multiple trips from here to the Indianapolis to, you know, stop at Brazil and Plainfield on your way to Indianapolis, which is only an hour. And you know, even more embarrassing sometimes is leakage. And so urinary leakage is a quality of life concern. And so these things, all joking aside, do result in quality of life concerns. And so to address this quality of life issue, we initially, you know, can treat these folks with medications. But what this presentation is going to focus on is trying to get away from those medications, because those medications do have side effects. They cost money. You have to remember to take them. And at the end of the day, they don't always work as well as we'd like them to. So we're going to go ahead and get started and talk a little bit about the prostatic urethral lift or Eurolift system, which addresses this enlarged prostate. So bear with me for 1 second as I pull this up here. Okay, so let's get started here, and we're going to go ahead and talk about, you know, what is BPH. And so BPH is a fancy way of saying an enlarged prostate or benign prostatic hyperplasia, which causes a plumbing problem in the urinary system. And we'll go over some simple anatomy so that you can get an idea of exactly what this is. And so, as you can see here, these are the top 10 reasons that folks come to visit me in the urology office. And so BPH, as you can see, is one of the more common and the most common reason that urologists in the United States see patients in the office. And following that is surgery follow-up, of course, prostate cancer, penile disorders, urinary tract infections, kidney stones, hematuria, which is blood in the urine, and then bladder function disorder, which typically encompasses male and female lower urinary tract symptoms, urinary incontinence, in bladder problems in women. And so the BPH is really what we're going to focus on tonight. And so what are the numbers? And so what's important to know about enlarged prostate is that it occurs only in men, of course. Only men have prostates, and the prevalence increases with age. And so as we age, we see that this prevalence of enlarged prostate rises significantly. So in men that are 50 to 59, the numbers are about 30%. 30% of those men experience some degree of urinary symptoms from enlarged prostate. As we age 60 to 69, those folks, about 70% of those men experience urinary symptoms. And then as we continue to age, 80% of men have urinary symptoms. And that's important to know because it is a disease of the aging men. And there are a lot of men that are out there that are dealing with this disease with only minimal treatment or no treatment. And so I wanted to talk to you, and we need to know a little bit about anatomy here. So anatomy is important to know, and it's important to get an idea of this disease process and why this is happening. And so what you can see here is the kidneys that sit atop at the top of your screen there. What their purpose is they have millions and millions of very small filtering devices called nephrons that filter our blood. As you can see, the aorta is the large red vessel there, blood vessel that sends what's called the renal artery to the kidney, and that is coming from the heart, and the kidney filters that blood, and those impurities that it filters become urine. And so that urine collects in the collecting system in the kidney, and then that drains in the tubes that you see that are leading down to the bladder over top of the red and blue vessel, which are the aorta and the vena cava, and then drape behind the bladder to insert into the bladder and drop urine into the bladder. The bladder is the storage unit where urine is stored. And at the base of the bladder, as you can see in this next diagram, at the base of the bladder is the prostate. And so the prostate is an organ that I like to describe very similar to a donut, in the sense that it does encircle the urethra. And so that's very difficult to understand unless you've actually seen the anatomy, but the prostate is encircling this urethra. And what happens as we age, the prostate tissue encroaches on the urethra and causes this plumbing problem that we can see here. And so what happens is that the bladder is a muscle, and I always describe this to my patients this way, is that the bladder muscle, which you can see this thick bladder wall here, and the prostate that sits at the base of the bladder. On the left of your screen, you have a normal prostate and a normal bladder. On the right of the screen, excuse me, you see an enlarged prostate and a bladder that's being affected by this enlarged prostate. And so what happens is this prostate encroaches this tissue. The tube, which is the urethra, is very distensible, meaning that it will open and close with pressure, with extrinsic pressure from the outside. And so this prostate results in this pressure, and it creates a pressure flow dynamic between the bladder and the prostate. So I use this analogy, as I was alluding to earlier, of a heart. And so a heart's a muscle that pumps against the blockage. That blockage typically is the coronary artery. But the point is that the heart can become pooped out from pumping for many, many years against an enlarged prostate. And those men and or women that have, or excuse me, against the coronary artery, and those men or women that have blockage in their coronary arteries and have a heart muscle that's tired, they have a heart attack. And so in very similar fashion with the bladder is a muscle, and it's pumping against a blockage, which in this case is the prostate. And that bladder muscle is working overtime and working very, very hard. And that bladder muscle can decompensate. And that decompensation of that bladder muscle is what causes the lower urinary tract symptoms that men are bothered by. Lower urinary tract symptoms is really a fancy way of saying the bothersome symptoms that results from this disease process. And so those lower urinary tract symptoms are everything from urinary frequency, urinary urgency, nighttime urination, incomplete bladder emptying, intermittency, the starting and stopping of your stream, and straining. And these things cause a quality of life issue. And so as you can see on this right picture, the enlarged prostate is so big that it's actually completely occluding the urethra here, and it's protruding into the bladder. This protrusion into the bladder is called intravesical protrusion. That intravesical protrusion results in a higher grade obstruction that can cause even more bladder dysfunction. And so this obstruction that's caused here, the idea here is to address it sooner rather than later, so we avoid this bladder dysfunction. And so we avoid bladders that are unhealthy and may not squeeze down and empty our bladder. If we wait too long, this bladder may or may not be able to squeeze down and empty itself. In that situation, a man may need a catheter to empty his bladder. And so what we don't want to do is get to that point. And so we try to preserve this bladder health by addressing this sooner rather than later, which is what we'll talk about here. And so again, I see patients in the office quite a bit for this, and this patient presentation is a very common patient presentation that we'll see. And so this man is a 65-year-old male with bothersome lower urinary tract symptoms, which have progressively worsened over the past 5 years. So it's important to know some past medical history, because past medical history can result in some urinary symptoms as well. And so this gentleman has diabetes. He has a history of hypertension, history of hypothyroidism, and erectile dysfunction. His meds include lisinopril and hydrochlorothiazide, metformin for his diabetes, Synthroid for his hypothyroidism, and Viagra for his erectile dysfunction. Family history of enlarged prostate without the history of prostate cancer, which is very important to delineate, as prostate cancer patients are not candidates for minimally invasive options. They require more aggressive treatment options for cancer. And so this gentleman's International Prostate Symptom Score, which is a score that is indicative of how this gentleman's been urinating over the past month, was 25. So this score is composed of the things that we talked about before that the bladder and prostate result in. So the score is out of 35, 0 to 35. The higher the number, the worse the score, of course, and the worse their symptoms and the worse their quality of life. And so this gentleman with the score of 25 has moderate to severe symptoms. 0 to 10 is mild, 10 to 20 is moderate, and 20 to 35 is severe. And so this gentleman has a score of 25 with a mostly dissatisfied quality of life score. And that's the important part of this, is that this is a quality of life concern. And many times the nighttime urination is one of the more bothersome symptoms, as men are getting up multiple times a night. Again, they're waking up their wives. They're have the potential for falls and fractures, and all the things that come along with not being able to get a good sleep. Not getting a good sleep can result, if you're unable to string together 2 to 3 hours of sleep at a time, we do not get in the REM sleep, which is the rapid eye movement sleep. That rapid eye movement sleep is very important for restful energy the next day. And so getting up multiple times at night results in a negative effect on that quality of life and can result in decreased energy, absenteeism, decreased productivity, fatigue, testosterone issues, psychological issues, all the things that come along with not getting a normal amount of sleep. And so moving forward with this gentleman, his primary care physician placed him on Flomax, but experienced negative side effects with this Flomax and wanted a different treatment option. This happens quite a bit, as the primaries very commonly do recommend medications for the prostate, whether they're specific for the prostate or not, but the primaries do usually prescribe those, and those medications are typically Flomax. That's the first line therapy for any man with an enlarged prostate. And so he was on this medication for an extended period of time, but experienced negative side effects and wanted a different treatment option. So alternative to medications or alternative meds. And so the few options for this gentleman are, of course, addressing the things that may cause his symptoms to be worse. And so we always need to address dietary and lifestyle as potential contributors to his urinary symptoms, and bowel and bladder problems. Bowel and bladder problems go hand in hand. And so bowel problems result in negative urinary symptoms. So constipation, diarrhea can result in negative urinary symptoms. So I always address this with my patients. I always address, this gentleman has diabetes. And so if his sugars are out of control, then he's going to be urinating more than normal because of his sugars. Diabetes ravages the urinary system in that regard, and can result in frequent urination, urgent urination. And many times that's because the blood sugar is so high that the kidneys cannot handle that, and they filter that blood sugar and it gets spilled in the urine, and where sugar goes, water follows. And so these men very commonly urinate a lot unless they have good control of their sugar. So glycemic control is very important in these gentlemen. If you can recall, this gentleman was also on hydrochlorothiazide. So hydrochlorothiazide is a medication used for hypertension that can cause urinary frequency and urgency. So at the end of the day, yes, the man has an enlarged prostate, but we do need to be cognizant of the things that may contribute to this disease. And so a few things we can do is we can double up on his Flomax. And so many times doubling up on Flomax causes double side effects. And so that isn't always the best option. In some men, it does help. The studies do show that the 0.4 milligram dose is the most optimal dose. Doubling it to 0.8 milligrams potentially can provide some minimal relief and some placebo effect, which is not to be unentertained. So another option is daily Cialis. And daily Cialis, the FDA approved Cialis for both enlarged prostate and erectile dysfunction at a very low dose on a daily basis. Unfortunately, this medication does not have robust responses in the prostate and the bladder, and does not significantly improve urinary flow. And really the mechanism of why this happens or why this improves urinary flow is yet to be uncovered. And so We can also do this. We can talk about medications that address the bladder. And so Flomax is a medication that works specifically on the prostate and works by relaxing that prostate, relaxing the donut hole, relaxing the tension that the prostate's putting on the urethra. Other medications that focus on the bladder, unfortunately, they do not focus on the problem. And the problem in this situation is the prostate. And so men with enlarged prostates, you can address their bladder because those bladder symptoms are a result of the prostate. But the bladder medications that we use often have side effects. And so very commonly using these medications in older folks, which this is a disease of the older folks, is ill-advised, especially those medications that are anticholinergics. Anticholinergics like Detrol LA, Toviaz, oxybutynin, Vesicare, those medications they do work, and they do work by decreasing the overactivity of the bladder. The only problem with these medications is that in folks over 65, it causes ultramental status and very commonly can cause dry eyes, dry mouth, and constipation. And so these are things that can negatively affect someone's quality of life. And especially in folks that are over 55, I try to avoid these medications at all costs because number one, we're addressing the bladder and not the problem, the prostate, but they also have side effects. Another medication that's a nice option is what's called Merbetrik. Merbetrik is a beta-3 agonist that works by also relaxing the bladder, but has very few side effects in comparison to the anticholinergic medication. So it is a decent option, but again, focusing on the bladder, we're not focusing on the problem, which is the prostate, the plumbing problem. I always joke with patients that I'm a glorified plumber. So, what do plumbers do? They get rid of plumbing problems. And so that's what I do. I get rid of plumbing problems, or I address plumbing problems, and that plumbing problem is the prostate. So surgical treatment options then is the next sensible course of action. And those surgical treatment options, the history of these surgical treatments dates back all the way back to the 1920s. A gentleman by the name of Maximilian Stern in 1926 made the first receptoscope. And so I want to show you this really quick before we go back to the last slide. But this is what's called a receptoscope. And you can see this is looks like a medieval torture device, and so what this is it's a sheath. It's an open sheath here that these instruments that you see at the bottom, they have a fine wire loop, and that goes through that sheath, and there's a water port where water is irrigating the bladder, and this loop, this heated element wire, is used to resect the prostate or remove this obstructing tissue. And so this has been around for a very long time and is still the gold standard and still very much part of the American Urologic Association guidelines when it comes to treatment for enlarged prostate, as it does remove the prostate and results in significant disobstruction, meaning removal of that plumbing problem. The only problem with this is that it can cause adverse side effects, and those adverse side effects are side effects that men and their women don't want them to have. And typically those are sexual side effects. And so what happens with the TURP is we remove that prostate. We can do that in a few different ways. You see all these ways we can do that. We can do it with a laser. We can do it with a robot. We can do it with the heated element. So there's multiple ways to do the same thing, addressing this plumbing problem. Unfortunately, these result in a significant amount of erectile and ejaculatory dysfunction by virtue of the tissue that it's destroying. And so as we move down here, you can injure, heat, or ablate prostate tissue. And in doing that, it causes some significant side effects. And those side effects are typically due to the heat therapy. And heat therapy and energy delivered into the prostate results in very bothersome lower urinary tract symptoms or frequency, urgency, nighttime urination for an extended period of time. And so the goal of the Eurolift was to get away from these more invasive procedures and come up with a procedure that has very minimal side effects, in particular, very minimal sexual side effects, which comes along which the medications and the procedures for enlarged prostate can cause. And so lastly, we see here three. The Uroloom was a prostatic stent that was basically like chicken wire, and it was a tube of chicken wire that went in our urethra. expanded and did immediately open the prostate, but unfortunately it encrusted and caused significant ingrowth into that tissue, and getting that chicken wire out of that tissue deemed very, very difficult. So that's something that has been no longer in practice, and something that I would not recommend. So this is the Receptoscope that we talked about. Things have changed as technology has advanced. This looks a little bit different, a little bit more space age in this piece of equipment here. And so let's talk about here what is the current state of the BPH population. And basically what that is who am I seeing and how are they being treated? And so 34% of men, 4.3 million patients, are undergoing what's called active surveillance, or excuse me, watchful waiting. Watchful waiting is basically hoping that these symptoms do not progress and really doing nothing. And in doing that, that can result in problems because it results in a progression of this disease and a progression of the bladder decompensation. And so watchful waiting is about a third of the population. A little bit more than half, at 64%, are undergoing some kind of medical therapy, 7.9 million patients. And then look at this, only 2% undergo surgery or a procedure. Less than 250,000 patients are undergoing some type of procedure for their enlarged prostate. And so that's an issue in that we are not addressing a lot of these men that may be on watchful waiting or medical therapy. And then as you look at the right of the screen here, you see that each year 16.3% or 2 million discontinue their drugs. Why do they discontinue these drugs? Well, they discontinue them because they're not getting any relief from their drugs, and they're having sexual side effects that both the man and the woman are not very pleased about. And so the nice thing about the Eurolift system is that it's a proven option for patients seeking an alternative to medications and more invasive procedures. This Eurolift was FDA approved in 2013. It's been around quite a bit longer in the UK and the Australian market. But the LIFT trial is the FDA approval trial, which resulted in its FDA approval, and we'll have a graph on that here shortly. But so 100 urologists and practice administrators were surveyed, and the percentage of those folks that said that BPH patients should receive advanced BPH therapies are more than 30%. So what that says is that more urologists think that more patients should undergo more advanced treatment for their enlarged prostate. So we just need to capture this patient population and address this sooner rather than later. And so do BPH drugs address bladder outlet obstruction? So what's bladder outlet obstruction? It's the same thing as enlarged prostate. The bladder outlet obstruction is the enlarged prostate causing this plumbing problem. So the effect of BPH medications on bladder outlet obstruction is minimal. So what that says is that these medications that we're using is really only minimally opening that channel. The increase in flow is significantly greater than placebo, but is still modest. So if we were to give these folks sugar pills and then medications, there is an improvement, but only a modest improvement. And so while giving these medications and while undergoing these therapies, unfortunately, their bladder health may suffer. And so bladder muscle or detrusor overactivity, which is overactive bladder, is prevalent in patients with bladder outlet obstruction. The reason that is because this plumbing problem, which is the prostate, keep going back to the prostate, is resulting in a pressure flow dynamic. That pressure flow dynamic is resulting in the bladder being overworked and underdeserved. And so in doing that, it causes frequency and urgency. And so the last bullet point here is it appears to persist, this bladder outlet obstruction and urinary symptoms appear to persist after watchful waiting or treatment with medical therapy. So really medical therapy, yes, it is mildly improving symptoms, but is not getting to the root problem. And that root problem is the prostate. So as described earlier, what we want to do here is we want to intervene early. The early intervention protects our bladder and preserves our bladder health. You'll see some pictures of some diseased bladders here in a second, but untreated bladder outlet obstruction may lead to irreversible bladder damage. In these folks that have irreversible bladder damage, that bladder damage results in inability to urinate and potential long-term catheterization. So what does surgery provide? Surgery in the form of either the traditional routes or the more minimally invasive routes, such as the Eurolift, the goal is maximal disobstruction, getting rid of the plumbing problem. I'm a plumber, I get rid of the plumbing problem. And so unfortunately, in these gentlemen, there is some irreversible bladder damage that may have occurred due to this chronicity of this disease, the long-standing urinary outlet obstruction. And so 6 months after an open prostatectomy, where the prostatectomy is completely removed, only 61% of these patients have complete resolution of their lower urinary tract symptoms. What that says and what that should mean to the patient is that even completely removing the obstruction, still 39% of these patients have some degree of lower urinary tract symptoms. Why is that? That's because of the long-term damage that's been done to the bladder. Hence the reason that we need to address this sooner rather than later. Address this overactive bladder by addressing the prostate. So men are bothered by lower urinary tract symptoms even when on prescription therapy, as in our patient presentation. And so 1 in 3 men are satisfied with the effectiveness of their medication. So only 33% of these men are actually happy with the improvement. 65% of men over the age of 50 are seeing a urologist and are interested in an alternative to medication for BPH. We need to capture that 65% because those are the men that need to be treated, and those men that are not being treated appropriately with meds. So 82% of men over 50 wake up at least 1 time per night to urinate on a regular basis. And the goal here is trying to get as much sleep as possible, decreasing this nighttime urination. So what's the problem with the medication first paradigm? The medication first paradigm, we run into problems very commonly because, as previously spoken about, the medication still results in progression of this disease in the bladder. And so causes of non-compliance with medication are cost. Many times these medications are very, very costly. Inconvenience, so it's inconvenient to take medications on a daily basis. And lack of effectiveness, which we've talked about, and side effects. And in this situation, most commonly, these are sexual side effects. And so reported compliance rates as low as 29% at 1 year and 13% at 4 years. So where are those other 71% of patients at 1 year, and then the 87% of patients at 4 years? Those are the patients that we need to talk to. And so patients have faced some hard choices when it comes to enlarged prostate and what they're going to do. And so as you see here on the left, this alpha blockers, that's a fancy way of saying Flomax. Flomax is the medication that our gentleman was on, and Flomax is the primary medication used for enlarged prostate. Now look what happens with this medication. Asthenia is a fancy way of saying fatigue, weakness, tiredness, dizziness, headache, nasal congestion, erectile dysfunction, ejaculatory dysfunction, reduced libido. Yes, there is an improvement in their International Prostate Symptom Score, that score, but unfortunately that comes along with all of these negative side effects. So 5-alpha reductase inhibitors are medications that are used typically in the older population to actually shrink the prostate. But again, you see asthenia, dizziness, headache, respiratory issues, ejaculatory dysfunction, erectile dysfunction, reduced libido. Yes, again, a modest, very mild improvement in their score and quality of life. So this is what happens to the bladder. And this is very important to see because a damaged bladder is something that once you see it, you don't want to have this. As you can tell that there's been some significant damage. And so this is, well, I'll show you some pictures here in a bit of a damaged bladder, but this is something that is caused from the plumbing problem. So earlier disobstruction has been shown to preserve bladder health, yet only 2% of these patients elect surgery or a procedure. And so again, preservation of the bladder health. So enlarged prostate meds provide symptom relief, but do not adequately address the bladder outlet obstruction. Remember that bladder outlet obstruction is the key. Untreated bladder outlet obstruction may lead to irreversible bladder damage. I'm not sure if you can see my pointer here, but this is a healthy bladder, nice and smooth. This is a bladder that you can see has these muscle fibers cross-hatching here are unhealthy. These are all due to a plumbing problem and from chronic outlet obstruction from this muscle pumping against a blockage for years and years. If you do 1,000 bicep curls, yes, you have a big muscle, but it's weak and tired and can become damaged. And so this is a permanently damaged bladder. This man may or may not need a catheter to empty his bladder. So we need to address obstruction earlier in the disease. And so the solution is what we're getting ready to talk about here, which is the Eurolift. And so this is a trabeculated bladder that has been damaged from chronic bladder outlet obstruction. You can see these muscle fibers cross-hatching here, which is called trabeculation. If it gets bad enough, you can have these holes in the bladder called diverticulum, very similar to diverticula that you get in the bowel. The diverticulum that result in diverticulosis or diverticulitis is typically due to back pressure from constipation, for example. Same thing here. This back pressure is the prostate working and the bladder working against this enlarged prostate. So look at these diverticulum. These are huge diverticulum that are almost the size of the native bladder. In this situation, these diverticulum are not backed by muscle. And so if not backed by muscle, guess what? These do not empty. So very commonly, urine sits behind in these diverticulum. Urine that sits behind in these diverticulum is a setup for a urinary tract infection. Why? Because static urine or urine that is not moving is a breeding ground for bacteria. And in order to empty this, it may be very difficult to achieve that with some kind of procedure, as this damage has already been done. Men that do have this problem are candidates for a Eurolift, but this is chronic bladder damage that it may have some permanent and irreversible damage to this bladder, or will have permanent and irreversible damage. You can also get bladder stones. These are big bladder stones that are created from just stagnation of urine and a decrease in the flow. I always tell folks that it's like a river and a swamp analogy. A river is always flowing and it's nice and clear, and so that river, typically not a whole heck of a lot of bacteria in that river. In the swamp and that swampy water is stagnant. It's not moving, and so that stagnant urine results in calcium deposits and oxalate deposits, and that results in bladder stones. And so again, this is a very, very large burden on the medical system and causes billions and billions of dollars on the medical system on an annual basis. And not only that, it causes quality of life issues. So this is very important, and we'll continue to talk about it here. And so how do men define minimally invasive? Minimally invasive in a man's mind is no postoperative catheter, which in all the other procedures, most of the other procedures, nearly all of them, you will have a catheter postoperatively, and potentially that catheter will be in for a long period of time. That, when I say long period of time, I mean typically less than 1 week, but still longer than a catheter needs to be in. So they want no post-op catheter. They want rapid relief. They want rapid recovery, minimal downtime. They want to get back to work, minimal procedure discomfort, preserve sexual dysfunction, which is important in many men and women, and it can be done as an office procedure and with local anesthesia. So the advantages of this are typically no catheter required after the Eurolift system. There's rapid symptom relief and recovery, and there's preservation of sexual function, and it can be done as an in-office procedure. So the Eurolift system has extensive clinical data to support this. And so the LIFT trial, which was the FDA approval trial, has given the Eurolift 5+ year durability, which puts it right up there with some of the procedures that get rid of the tissue. And so in this situation, as you'll see coming up, is we're not resecting or getting rid of tissue in this instance. We're actually just moving the tissue out of the way. So it's been proven in the real world. There's been hundreds of thousands of these procedures performed all over the world, more than 500,000 in the United States and in clinical practice. And it's a very good option for men that are the ideal candidates. And so this is a representation of the LIFT trial and how this procedure got FDA approved. So what's also important to know is that this procedure has been part of the American Urologic Association guidelines, and knowing that as physicians, we follow guideline medicine. And so having this recommended in the guidelines is very, very important, because it helps urologists and also patients move forward with this decision to go ahead and address this bladder outlet obstruction. So the AUA guidelines, which is the American Urologic Association guidelines, says that urologists should consider prostatic urethral lift or the Eurolift, and they should be made aware that surgical treatment, the old school treatment options that we talked about, can cause ejaculatory dysfunction and may worsen erectile dysfunction. AUA guidelines continued here. They say this: since many men discontinue medical therapy, yet proportionally few seek surgery, there's a large clinical need for an effective treatment that is less invasive than surgery. With this treatment class, perhaps a significant portion of men with bladder outlet obstruction who have stopped medical therapy can be treated prior to impending bladder dysfunction. So again, here's the picture of the healthy bladder to the permanently damaged bladder here. This is a patient testimonial about the Eurolift, and we're going to skip that for today. And so this is the procedure itself. And so this procedure is typically done under very minimal anesthesia, either in the office or the operating room setting, and is typically, in my hands, about a 10-minute procedure. Most men do not go home with a catheter. Most men afterwards can expect some urinary frequency, urinary urgency, some blood in their urine, and a little bit of discomfort. So this is how this procedure works. An enlarged prostate is this picture on the very left. The step one is using a telescope to actually visualize the prostate and determine where we're going to place these implants. Step two is placing the implants through and through the prostate. I always counsel patients that the prostate's like an orange. Think the prostate like an orange, and the orange rind is the capsule of the prostate. And that capsule of the prostate is very thick and fibrous and can hold implants in very tightly. And so that's what happens here, and you'll see that in the video. But lastly, after all these implants are placed here, you can see that there's a significant improvement in the channel here, which results in a significant improvement in flow and a decrease in this urinary symptoms.
The Eurolift system is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The Eurolift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructed prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally.
I'm getting text from my wife that you weren't able to see that animation. I'm sorry. I'm not sure why that's not working. Again, one of these technical difficulties that unfortunately I'm not going to be able to show you that unless there's another way I can do that. Maybe I can at the end of the presentation. We'll keep moving on here. I think. My apologies. My apologies. I think you guys sat there for a minute, minute and a half without anything. There's supposed to be a video of the actual procedure, but that didn't show up. So at the end of the day, what this procedure is doing is this: is you can see the prostate here in this picture on the left, and so this is the obstructed prostate. And this obstructed prostate is causing the plumbing problem. And we keep going back to that plumbing problem, but that's what it is. And so you can see after the implants have been placed, these implants have moved this tissue out of the way. And from the sphincter muscle, you have a direct vision into the bladder. That is absolutely what you want to see after a Eurolift, which results in the improvement in the urinary symptoms. So post-operatively, patients can expect, as I said, urinary frequency, urinary urgency, some burning, and a little bit of bleeding. All of this is normal, and it will last for up to about 3 or 4 days. After about a week or two, you'll experience significant improvement in urinary symptoms, and those improvement in the symptoms can be enjoyed up to about 3 months. So there's benefit up to about 3 months, and then the symptoms stabilize, and at that point in time, you have a baseline of what your urinary symptoms are going to be. So in summary, the Eurolift system is indicated for the treatment of symptoms due to urinary outflow obstruction secondary to enlarged prostate, including both lateral prostate and median lobe prostate in men over 45 years of age. And so the most ideal patients for these procedures are men that are candidates for the procedure. And so prior to moving forward with a procedure like this, all men undergo a cystoscopy, which is a telescope test in the bladder, to ensure that the man is a candidate for this procedure, and an ultrasound to see the actual size of the prostate. We measure the height, the width, and the length of the prostate, which actually does play a role in planning of these implants. And so in patient selection, men who have BPH, who want increased symptom relief, want off their medications, want to preserve their sexual function, would prefer a less invasive option. Another thing to say about this procedure is that it's done in about 10 minutes, whereas the other procedures take many times hours. And so anesthesia is also a concern. The longer period of time under anesthesia is something that we want to avoid if at all possible. And so that's important to also counsel these patients on as well. And so patients that are candidates for the more invasive procedures, who are candidates for the Eurolift, are those that are concerned about complications from the more invasive procedures. They want to preserve their sexual dysfunction, or preserve their sexual function, which they would not if they got a TURP or laser procedure, and want a more rapid return to daily life. So thank you very much, everyone, for joining me this evening for this first Zoom mini medical school. I hope that you enjoyed the discussion that we had regarding enlarged prostate, and I'm happy to do another mini medical school that's everything women in urology. I know that the women were misrepresented in this, but in all seriousness, it does affect the women in our lives and the women in my patients' lives. And so I do want you to know that at the end here, please feel free to ask me any questions, women's health, men's health, whatever it may be. If you are interested in an appointment, you can contact the office. Our office is located on 3401 South 4th Street in Terre Haute, by the Dairy Queen there on 4th Street, and then our office number is there at the bottom. So thank you again very much. Thank you, Kennedy and Jackie, for setting this up, and thank you for allowing me to counsel the community that I live in, and I'm happy to take care of any of you if you have any problems, whether it be prostate or other.
Thank you so much, Dr. Shanks. At this time, we are going to take a 5-minute intermission, and during this break, a pop-up window is going to appear on your screen. If you guys could just take a few seconds to answer those questions, that we're just trying to collect some basic audience information. And then we're going to have our question and answer session in 5 minutes. And you can answer or ask any question that you would like by clicking the question and answer button at the bottom of the screen. And if you don't see it, you should be able to click the more button, and it should be in there. And we will be back in about 5 minutes, and we will address all those questions. Okay, we're going to go ahead and resume this session and jump into the question and answer session. And attendees, please feel free to continue submitting questions if any more come to mind. And Dr. Shanks, we'll start off with the first one in the chat box. And that is Flomax hurtful for those with cataracts or eye surgery?
Flomax needs to be used with caution in folks that are undergoing eye surgery and cataract surgery, because it can cause a condition which can cause some permanent damage to the eyes. So at the time of surgery, that medication needs to be stopped. Prior to and afterwards, it's not as big of a deal, but it needs to be made aware to the eye surgeon that they're on that medication, and according to their recommendations, they would probably stop it in anticipation of the procedure.
What are treatment options available for females with urinary frequency and urgency?
What are treatment options for females with urinary urgency and frequency? So a few different options depending on the age of the patient. Usually these women are women that are a little bit older, and the few options, of course, are counseling these women on dietary and lifestyle modifications, avoiding caffeine, alcohol, spicy, acidic foods. Those are the 4 bladder irritants. Not completely doing away with them in your everyday routine, but knowing that they do cause urinary frequency, urinary urgency, and then addressing the other medical problems that they may have, such as diabetes or obesity, or some of the other problems that may be contributing to that. But when it comes to medications for overactive bladder and urinary frequency and urinary urgency, typically one of the first line options is an anticholinergic medication, which is the medications that I had spoken about earlier. I'm not a big fan of those in folks over 65, or excuse me, folks over 55, because of the reasons I stated: the dry eyes, dry mouth, constipation, altered mental status. In younger folks, it's not as bad, and it does work very well. Also, Merbetrik is one of the new kids on the block. It's a beta-3 agonist, and it does a very similar has a very similar action to anticholinergics, but doesn't have the side effects, doesn't have as bad as side effects. And so in those folks that fail conservative treatment options, depending on, on the symptoms, but if they fail conservative treatment options for frequency and urgency, such as medications, dietary lifestyle modifications and medications, then other treatment options are like Botox. Botox is an option that's delivered into the bladder that has a very long, robust treatment response, up to about a year, can be up to about a year, and decreases the overactivity of the bladder, the frequency, the urgency, and actually leakage. It can altogether stop leakage, but it is a temporary fix, and it does only last between 6 and 12 months. There's a bell curve, so some women get 6 months, women get 12 months. A lot of women get about 9 months with the Botox. There's implants that we can put into the sacrum, into the sacral foramen, which is the area that feeds basically the pacemaker of the bladder, and those leads that stimulate those nerves can cause decrease in urinary frequency and urgency as well. Initially, we always counsel women the frequency and urgency, making sure that their bowels are in order as well, because constipation can result in significant urinary symptoms, frequency, urgency, those type of things. And once those things have been addressed and the dietary and lifestyle modifications have been addressed, then we talk about medications.
Okay. And this is about the Eurolift procedure. For some men, they do participate in anal intercourse. If they do have this procedure, would the intercourse be damaging to the wires that are inserted in the prostate?
No, it would not be damaging at all.
And are there any types of diet that would prevent or delay the prostate from enlarging?
No types of diet that would prevent and delay. There are some herbal supplements that can help with symptoms, like saw palmetto and pumpkin seed are 2 things that are alternative treatment options and herbal. And if patients have success with these treatment options, I absolutely recommend them if it's working for them. They don't have as robust of a response as the medications, but there is no specific diet, no specific things that you can do that are going to decrease the chance that this prostate is going to grow. It's because we have a Y chromosome, and because we have androgen receptors, it's going to grow as we age, and that's just part of the aging process and the prostate health as we age. Excuse me.
Okay. If somebody were to get this procedure done and then like later on down the road, like a few years later, they start having symptoms again, is it like a procedure they can do multiple times?
It is. It is. So there are men that have had the procedure and 5 years out, say, hey, doc, I'm having some recurrence in my symptoms. I really don't know what's going on. So very commonly, regardless of whether you resect the tissue, get rid of the tissue by cutting the tissue or move it out of the way, with the implants, the prostate tissue is going to regrow. There's prostatic regrowth. And so in, say, 5 or 10 years down the road, if there are recurrence of symptoms, then we would take a quick look with a cystoscope into the bladder and see where this obstruction is being created. And if they're a candidate, then absolutely put more implants in. Or then the beauty of this is that we don't burn our bridges, and these men can undergo other procedures like a TURP procedure.
Okay. Is the urge to urinate still intact post-procedure, and also the ability to hold in one's urine?
Yes, the urge to urinate is still there. The ability to hold the urine is still there. Why? Because the sphincter is still there. So the sphincter is not addressed, and so it stops the urine. But what I would say is immediately post-operatively, or a week or two post-operatively, that urgency and frequency will be there just by virtue of the procedure, but will progressively improve. But yes, the urgency will improve, and the ability to hold the urine, leakage improves as well.
Okay. Do you know if the procedure is covered by Medicare?
It is most of the time. We run into some issues there, and we have to get a prior authorization, and I have to talk to somebody, but usually we can get it covered.
And this is not related to the procedure. This is related more to just women's health. Does cranberry juice actually help with UTIs?
So yeah, cranberry juice in a modest way does help with urinary tract infections if used correctly. There are 100 different cranberry supplements over the counter, and really the studies show that you need 360 nanograms of this of the active ingredient to actually decrease the chance of recurrent urinary tract infections. So there's been randomized controlled studies that have showed that cranberry will decrease the chance of urinary tract infections modestly, and but it does need to be a good amount of cranberry. So just drinking cranberry juice in and of itself, typically you do not get the amount that you need. And so there are over-the-counter prescriptions that do have the appropriate amount of cranberry, and there's also other cranberry supplements that I recommend that have that amount of cranberry and have been proven to decrease the chance of urinary tract infections. The way that it's doing that is that it's acidifying the urine, or causing the urine to be more acidic, which causes the bacteria not to be able to basically use their pili, as the medical students may know, their arms to grab onto the bladder. And so those E. coli bacteria are less likely to adhere themselves to the mucosa of the bladder if you're on cranberry because of the acidity of the urine.
What is the most common reason you would see women in your office?
Most common, I was starting to type that response as we're on the break. And so the most common reason I see women, I see women for a lot of things, kidney stones, bladder cancer, kidney cancer, other problems. But one of the more common reasons I see women is urinary incontinence, especially those women that have had multiple vaginal births, multiple C-sections, pelvic surgeries, but childbearing is not easy on a woman's body, and it causes a stretching of the pelvic floor muscles, and can cause some overactive bladder symptoms, and sometimes some stress incontinence, coughing, laughing, sneezing, causing incontinence, and that is treated typically with a sling. Overactive bladder in and of itself, if it's a purely overactive bladder, urgency and frequency without stress maneuvers, coughing, laughing, sneezing, causing urinary incontinence. I see that a lot as well. But urge incontinence, stress incontinence, overactive bladder, recurrent urinary tract infections, lots of recurrent urinary tract infections, atrophic vaginitis, microscopic blood in the urine due to atrophic vaginitis. But usually it's urinary symptoms in women that I'm seeing them for, and bothersome urinary symptoms.
Okay. And these questions are more related to your life, and they're basically just asking if you could provide a quick overview of your educational journey and what made you choose urology, as well as how you ended up working in global medicine as well.
Yeah, so I'm from Terre Haute, and I went to Terre Haute South, and after that I went to I did my master's degree I went to DePaul. I was skipping college. I went to DePaul in Greencastle and graduated from DePaul. And after DePaul, I did some work in Indianapolis as an EMT, and then I went and did my I guess I should preface this with I was raised by my grandfather. My grandfather had bladder cancer. So that's one of the reasons that urology interested me. And he had his bladder removed at Mayo Clinic. And I was taking care of his ileal conduit, which is a bag that he would need to wear after having his bladder removed. He was a smoker, and he was in the military, and he had bladder cancer. So that's the reason that I got interested in urology. But my education after DePaul, I did my master's program in renal physiology, thinking that I wanted to do research, and I studied the rats' kidneys and decided that I didn't really want to be doing surgery on rats. I'd prefer to be treating humans. And so I went to medical school from there, naturally having a background in renal physiology or kidney physiology. And my grandfather's history, I decided to go into urology. I trained in Chicago. I was there for about 10, 12 years. And after that, I decided to come back to the community that brought me up. And so that's what brought me back to Terre Haute. As far as my medical missions go, my wife traveled to Africa multiple times prior to our getting married. And so I went with her on a medical mission trip. We were doing village medicine and really just doing kind of general medicine. And I absolutely fell in love with it. And we went back to Burkina Faso in Africa three times, I think. And after that, in medical school with some medical school friends, we went to Haiti after the earthquake and did hurricane medicine and lots of crush injuries and lots of things that came along with the hurricane. And then most recently, I was dropped off in the middle of the Amazon in Bolivia, and that was quite the experience. I just like adventure, and I like to help people, and it's a fun way to, use my skills for people that have never seen a physician. And, the first time I went to Bolivia, I just did vasectomies on the village men that, we're not really wanting to have more children. And so, I do as much as I can traveling and experiencing the world. And so, but really, I guess I can thank my wife for getting me started in the mission work. So.
That's awesome.
Yeah.
Thank you so much. I think that looks like the last question that we have for the night. So that's going to conclude tonight's mini medical school. Thank you once again to the wonderful Dr. Shanks for your awesome presentation. And thank you to all of the attendees for joining us and sharing their questions. We hope that you'll join us again. Mini Medical School will be every Tuesday in March and April from 6:30 to 8:30 via Zoom, with the next topic focusing on diabetes. Before ending the meeting, we ask that you once again answer the pop-up poll questions that popped up on your screen during the intermission. Your feedback is anonymous, and it will be used in the planning of future mini medical school sessions. Thank you all so much, and I hope you have a restful rest of your night.
Thank you.